Gastrointestinal means dealing with stomach and intestine. So these are the patients you'll be called to that are having abdominal pain as their common complaint. And so just as we said in psychiatric emergencies, can be caused from a host of issues. So the same thing with abdominal pain. There can be several causes of abdominal pain. And so it's not for the EMT or the EMS provider to determine the exact causes, but you must be able to recognize when there's a life-threatening situation and deal with it. So this is where you're gonna recognize that your knowledge of anatomy and physiology of the digestive and urinary system will be helpful to you to give you an idea of what is happening to these patients and what can be the pathophysiologies, the problems that can occur when these systems are not working properly. So what you will be focusing on out there in the field is the signs and symptoms and how you're gonna stabilize, treat and package and transport these patients. So with everything, ABC is gonna be first, and then you follow with what else is necessary. So we're gonna be looking briefly at anatomy and physiology. You would have covered all of these body systems in human body, and I told you when I was covering one of the topics that you're gonna be coming back to this throughout the course and throughout your career as an EMS provider. You must remember anatomy and physiology to guide you and give you an idea of what is happening and how you will need to manage these patients. So the abdominal cavity contains gastrointestinal system, and we say that system is made up of the stomach and the intestine. That's the key meaning for that word, gastrointestinal. And the genital system, which is comprised of the reproductive structures, and then you have your urinary system. So be mindful that the abdominal cavity contains both solid and hollow organs, which make up these three main systems. So you will have to remember these structures as we go forward. So for solid organs, you are looking at liver, spleen, pancreas, kidneys, ovaries, and the danger with these structures is that they are very vascular, some more so than other, and so when they are injured or problem with them, they are gonna cause bleeding, and so it can lead to shock and also irritation of the peritoneum, as we will see going forward. So solid organs, vascular, so you're looking at bleeding when there's a problem with them, and so blood will be let into the peritoneum and cause irritation and can lead to shock. So that's gonna be your primary concern when you're considering that there's a injury or problem with the solid organs. So with the hollow organs, we are looking at gallbladder, stomach, small intestine, large intestine, urinary bladder. So when these hollow organs are breached or there's a problem with them, they rupture, then the contents gonna be let out into the abdominal cavity or the peritoneum or the retroperitoneal area, and so the danger with these, unlike blood, which will lead to shock and irritate, they are gonna contaminate the abdominal cavity, and these will lead to peritonitis or infection and can lead to septic, and that's where the issue will comes in with these organs. So make sure you remember, solid organs will cause bleeding because they are vascular, so blood will be let into the abdominal cavity, cause irritation and can lead to shock. But with hollow organs, they have toxic or bacterial contents, so when they are let into the cavity, then they will set up the peritoneum to become contaminated or infected and lead to septic issues. So know your structures, and this diagram doesn't show it, but remember the abdomen is gonna be divided into quadrants. So just imagine a perpendicular line at the umbilicus or the navel, and so you will have two upper quadrants, left and right upper quadrants. You'll have left and right lower quadrants. So just imagine that you have that line that is dividing there, and so when you look right there, you'll have that lines that is dissecting perpendicular, and so you're gonna have structures that fall in each quadrant, and you must know what structure fall within each quadrant. So when a person is having abdominal pain in one quadrant, then you will have an idea what possible structures are involved, whether it be solid organs, which we say gonna be the liver. So the liver will fall in the right upper quadrant, and remember now that we're talking about the patient's right and left, not your right or left. So you're facing the patient, it's not your right or left, it's the patient's right or left. So the liver will be in the right upper quadrant. You will see the spleen on the left upper quadrant, and so you will have to note it based on that anatomical position. For the hollow organs, you will see here that you have the gallbladder, which says a hollow organ is on the right upper quadrant, and also the stomach will be on the left upper quadrant. So make sure you know it. And you have the descending colon here will be in the left quadrant, and it goes from the upper to the lower. Also, you'll have the ascending colon, part of it will be also in both quadrant, right, upper, and lower. So bear that in mind as you look at the structures. So once the person is having that abdominal pain, your knowledge of the structures that fall within each quadrant will give you an idea of what is happening. So the gastrointestinal system we're looking at, we said those that combined word is stomach and intestine. So it's responsible for the digestion process, or we say it is the digestive system. So digestion begins when food is chewed. So the digestive system will start from the digestive tract is from the mouth to the anus. So that's the what we call a alimentary canal. So digestion begins when food is chewed. You have saliva that's gonna break down the food. The food is swallowed, and the food travels to the stomach. So the pathway is gonna be from your mouth. It's gonna go down the esophagus, and it's gonna enter the stomach. So there's a sphincter or a valve there that it will enter into the stomach. So food is swallowed and travels via the esophagus and into your stomach. So the stomach is the main digestive organ. So in the stomach, the food is gonna be acted upon by the acid, and so it will combine with the contracting motion of the stomach, and it convert that food, break it down into a form that we call chyle. So the chyle is the smooth paste-like portion that is gonna turn, and there is some absorption that is gonna take place in the stomach, but minimal. So the food is moved from the stomach into your small intestine, and it's gonna be the first section gonna be your duodenum. That's the shortest part of the small intestine, and then it's gonna be acted upon some enzyme and digestive juice from the pancreas and the gallbladder, and so it will cause further breakdown of that chyle, and then it will go to the second section of the small intestine, which is the duodenum, where the most of the absorption will take place of the nutrients, and then it will go to the last part of the small intestine, which is the ileum, where whatever nutrients that is left to be absorbed is done there, and then it will go into your large intestine. So the large intestine is referred to mainly as the colon, and so that's where the water will be absorbed. Whatever water is left in the alimentary canal will be absorbed in the large intestine, and that's where it's gonna be, what is left will be the waste, or turn into your feces or stool, and that's gonna go via the last part of the colon, the cecum, and then into your rectum, and it is passed out as stool via your anus. So that's basically how it is progressed. We will look a little further in it, but in a nutshell, that's how the digestion will take place, and then you will have other supporting structures that help in it. So the liver assists in the digestion. So the liver is gonna secretes bile and aids in digestion of fat. So you hear they say that the bile emulsify the fats, and so it breaks down the fat. So remember that is the liver that is gonna produce the bile, and it is stored in the gallbladder, and you have the bile duct that will take it to the first section of the small intestine, which you say is the duodenum, and so you have pancreatic juice coming in also, and enzymes will act upon the chyle which is coming from the stomach, and so it starts the process to break it down where the nutrients can be absorbed. So the liver also will filter toxic substances, so the liver is a big factor there. If your liver fails, then your body cannot filter those toxic substances, and so that's gonna be a big issue. And also it creates glucose storage. So remember these key functions of the liver, but as we are looking at the digestion is gonna be key in producing that bile, which is stored in the gallbladder, and then it's passed through the ducts. So the gallbladder is a reservoir for the bile. So the small intestine, we say the first part of it is the duodenum, and the digestive juices from the pancreas and liver mix. So the pancreas is gonna release amylase and bicarbonate and insulin. So we all know what the insulin is gonna do already, but we look at the bicarbonate. What the bicarbonate is gonna do is to dilute the acid that is coming from the stomach. So it's gonna cause the small intestine to be less acidic, which will help it. So that's the purpose of the first section of the small intestine, which is the shortest section, is to allow those juices to be mixed, and the bile that is coming from the liver, and that initial breakdown will start taking place there. So we say that the bile will emulsify the fat, and the digestive juice, the amylase, will break down the assist in the breaking down of the proteins, and so you will have that initial breakdowns taking place. When you reach the second section of the small intestine, which is the jejunum, and the absorptive process will be mainly taking place here. So most of the nutrients will be absorbed at this point in the small intestine, and so it is the part of the digestive system that does most of the work. So about 90% of the nutrients will be absorbed here and by the small intestine section known as jejunum. So the rest of it will be done in the ileum. So the last part of the small intestine is the ileum, and this is where whatever nutrients that were not absorbed earlier in the jejunum will be absorbed here, along with a lot of water also is absorbed by the small intestine, but the rest of it will be done in the large intestine. So also the bile that we said started from the first part, the jejunum, will be reabsorbed here and sent back to the liver, so it can be used for further processing. So also absorbed bile acids, so they can be returned to the liver for future use, and vitamin B12 for making nerve cells and red blood cells. So that's the function of the last section of the small intestine. Absorb whatever nutrients that were left from the initial process, and so it also absorbs the bile acid, so it can return for future use. So we'll be looking at the large intestine. So the large intestine, we say it is referred to as the colon, and it can consist of, from the diagram we saw earlier, you're gonna have the ascending colon, which is the first part of it. So where the small intestine meet with the colon or the large intestine, the first part here is gonna be the ascending section, and you have what they call the cecum is right at that junction, and so it's gonna go up on the right side. So it's gonna go through the right lower quadrant up to the right upper quadrant. It's gonna turn and become the transverse colon, going across the left and right upper quadrant, and then it will turn and be turned into the descending colon, which gonna be passing from the left upper quadrant into the left lower quadrant. So have that picture in your mind, and then it will loop back into the rectum. So that's the large intestine. So food that is not broken down comes here. Peristalsis moves waste through the intestines. Water is absorbed and the stool is formed. So in the large intestine, the food that is not broken down comes here. So whatever waste is left from whatever nutrient is taken out of the food that we eat, then that is what is going to end up in your large intestine. And peristalsis is going to be occurring all along the digestive tract, from the esophagus coming all the way down. That's what allows things to move in your blood vessels, your intestine. So it's the wave-like motion. It's a contraction going on that propels this stuff that is within these vessels forward, keep them moving in one direction. And so that's what peristalsis is. So it's gonna move the waste through the intestine. And we're talking about the large intestine here now, which is where the water is absorbed and it's become solidified to an extent. And so persons with diarrhea is where you don't have that absorption of the water taking place as much as it should, and so it's gonna be becoming watery stool instead of more solid stool. So stool is formed, and this stool is gonna pass from the last section of the colon into the rectum and pass out when appropriate time via your anus. So there's a valve there. So there's a valve, I should tell you, at the lower section of the stomach, which will release accordingly when the stomach is ready to empty its content into the small intestine. So there are valves along the way. So the spleen, we say it's a part, not actually a part of the digestive system, but it is within the abdominal cavity. So it is mentioned here. So it's located in the abdomen, no digestive function. It's part of a lymphatic system. So I don't know if you look at that before, but that's the system that's gonna help in filtering the blood, produce red blood cells, and it's act as a storage for blood, and so it and also produces antibiotics. So that's the function of the spleen. But for your information, since it's in the abdominal cavity, if there is problem there, then it can be affected, and so the person will present with the abdominal pain, which could be coming from an issue with the spleen. So that's why you need to recognize that also, and this spleen is very vascular. It's blood. So if it ruptures, then you know that blood will be released into the abdominal cavity, and we say can lead to shock and also irritation of the peritoneum. Well, actually, it's behind the peritoneum. So we are looking at the male. We are looking at the genital system. So male reproductive system contains the testicles or testes, the epididymis, the vas deferential, the seminal vesicles, prostate gland, and penis. So all these form the organs that make up the male reproductive system. So we are looking at where you can have problem with them that will show up in the problem with the abdomen. So the female reproductive system, you have the ovaries, fallopian tubes, uterus, cervix, and vagina. So the ovaries there, we saw from earlier that they are in the abdominal cavity, but they are going to be retroperitoneal. So they are not in the peritoneum per se, but they are at the retroperitoneal area. So they are behind the peritoneum, but they can be affected and cause problem which show up when you are doing your assessment of your patient with abdominal issues. So bear that in mind, and they go further down into the pelvic cavity and come into the outside. So when we look at the urinary system, so we say that there all three systems are contained within the abdominal cavity, and so they will show up when a person is having abdominal pain as possible those that are affected. So bear that in mind. So not only the organs of the gastrointestinal system you have to be concerned about, but recognize that organs of the genital system, and now we're looking at the urinary system, can also be affected. So the urinary system is the system that deals with discharge of waste material from the body, from the blood by the kidney. So the kidney have a big role there. It's gonna be filtering the waste, and so when there's kidney failure, that's gonna be a big issue, and that's where persons will have to resort to dialysis if the kidney fail and cannot cope with the load. Then in order for these persons to survive, they will have to get kidney transplant, and so sometimes that's not readily available. So to keep them going, they will have to resort to dialysis, where the blood will be taken out, put in a machine which gonna play the role of the kidney, and then filters it and then send it back into the person. So there are two kidneys, one on each side of the body. So it's lying on the posterior wall of the abdomen. So it's retroperitoneal, and it's gonna be there to regulate acidity and blood pressure. So it's gonna regulate the acid-base balance. So when it is too acidic, it's gonna release sodium and if the body become too alkalinic, then it's gonna retain it. So it act and it regulate blood pressure. So when the blood pressure drop, it will release some enzymes that will stimulate some function, and at a higher level you will go into what we call the RAA system, where they will have that control to regulate blood pressure. It's gonna rid the body of toxic waste, so it filters it out and it comes out in urine. So the kidney filters it, water and waste is filtered out, and then it's gonna reabsorb some of the water. So what is left will be urine. So mainly the toxic waste gonna be released in your urine. So blood flow is high in the kidneys, and so if the kidneys are working too hard, especially when persons have diabetes, that's gonna be one of the things that cause kidney failure. So diabetic patients, risk factor is there for renal failure. So you have the two kidneys on either side, we say in the retroperitoneal space, the posterior wall on either side, and then from the kidneys, after the filtration process takes place, and this what we call a glomerular filtration system, and then it comes into the collecting point and empties into what we call the ureters. So there is two ureters exiting each kidney, and so it comes into those ureters, and then it's gonna come to your bladder. So the bladder is in the more in the pelvic region, and so it's right behind the pubic symphysis. So that's where the bladder is located. So these two ureters will come into the bladder at the lower end of the bladder, and the bladder is going to empty into the outside via your urethra. So there is two ureters and there is one urethra. So these words sound the same. Make sure you know the difference. So ureters will come from the kidney to the bladder, and there is two of them, while the urethra is one tube that's gonna come from the bladder to the outside, and for male it's gonna come via your penis. For the female, it will come to the front section of the vagina. So it's gonna be longer in male and shorter in female, and that's why when we look at gynecologic emergencies later on, we'll see where it can, because of the shorter ureter, it will predispose the female to some diseases that the men will not have. So 1.5 to 2 liters of urine per day is produced, and so you can use it as a guide for some persons when they have issues. If there's blockage, then you will not be having that amount, and so you can use that as a guide to see when there is some issue. So know these structures, make sure you know the anatomy and physiology. And there we see the two kidneys on either side in the retroperitoneal space, posterior region, the two ureters coming down and collects into the bladder at the lower section of the urinary bladder, and then you will have the urethra coming out into the penis. This is showing your male urinary system. For the female, we said it would come to the front section of the vagina. So know these structures and can relate to them when a person is having abdominal issue, because they're gonna be in that same abdominal cavity. So once you know the anatomy and physiology, then you can look at the problem that can occur. So, Mr. Johnson, tell me one solid organ that we find in the abdominal cavity. Mr. Johnson. Mr. Shantilope. Are you in class?
Yes, sir. Liver, sir. The liver.
Which quadrant do you find the liver in?
In the upper right, sir.
Okay. Thank you, Mr. Shantilope. One
Ashanti
hollow
answer you.
organ. Sorry, Mr. Johnson. One hollow organ you find in the abdominal cavity. Mr. Michael Wilson.
Yes, sir.
One hollow organ.
That'll be the stomach and the small intestine.
Which all right. That's which quadrant do you find the stomach?
So that'll be the right upper quadrant.
You're talking about your right, not the patient right. Where is this?
So that'll be
where on the patient is the stomach?
That'll be the left upper quadrant.
Okay, so remember, it's not your right, it's the patient's right or left. Remember.
Yes, sir.
All right. Okay. So, Miss Rochelle, where is the kidney located? Space or retroperitoneal? Miss Rochelle. Okay, Mr. Manning. Where is the kidney located? Retroperitoneal or peritoneal space?
Yes, sir. Go again, sir. You're breaking up a bit. You said the kidney, where it's located, right?
Yeah.
Right,
yes.
sir.
Is it retroperitoneal space or peritoneal space?
That would be the retroperitoneal space.
Which is it?
Retro.
Okay. Miss Wellington. Thank you. Miss Wellington. What does the ureters connect?
Sir, they connect say the question again for me, please.
The ureters, what they connect? From where to where are they connected? What organs?
They are connected from the
ureters.
The kidney, sir.
To?
The bladder.
Okay, and they are referring to which bladder? Gallbladder or which bladder?
So I'm referring to the urinary.
About? You have gallbladder?
The urinary.
Okay, thank you.
Sir?
Okay, thank you. Yeah, thank you. You're correct. All right, moving along. So make sure you know your anatomy and physiology. Make sure you know your anatomy and physiology as it relates to the gastrointestinal, urinary system, and the genital system. So we're moving along to pathophysiology, problems that can happen with these systems that we call to attend to the patient. So the abdominal cavity is lined by the peritoneum. So the peritoneum is what covers the abdominal organs, and it has two parts to it. So just as in every cavity we have organs, just in the chest you had the same thing. visceral and parietal peritoneum. So the parietal peritoneum is the section that lines the wall of the abdominal cavity. So remember that this is the outer one. So moving in towards the body, you'll encounter the parietal peritoneum first. So it's lining the abdominal cavity. Then you have the visceral peritoneum that covers the organs. So that whole organ content can move within that space, and that's why you have it. Go ahead, Mr. Manning.
Yes, sir. I'm so sorry. Could you just repeat that again, sir, for me, please?
We said that the abdominal cavity is lined by the peritoneum. So the peritoneum is like a sac. So it's gonna be two parts to it. And we said this sac covers the abdominal contents, organs. So the abdominal organs are housed sac or peritoneum, but it has a two layers to it. So just as in your chest cavity, you have visceral pleura that covers the lungs and parietal pleura. It's the same thing in the stomach, in the abdomen. You have the parietal portion of the peritoneum, which is the outer layer that lines the wall of the abdominal cavity. Picture that. Then now you have another layer. It folds into another layer, which makes up the visceral peritoneum, and that's going to cover the organ. So just imagine that there's a double layer. One line the outside, which is the abdominal cavity wall itself, and then another layer that covers the organ. So it allows for the movement of the organ within that sac. And so there's a little fluid that is within that. Just this fluid in the parietal space, it's the same thing. So it allows for movement without less friction. So you have less friction there. Follow? Mr. Manning?
Yes, sir. Thank you.
So foreign materials such as blood, pus, or bile can irritate the peritoneum, and that's what we have developing peritonitis. So anything with itis means an inflammation. So if blood, pus, or bile is released in the peritoneum, then it's gonna cause peritonitis. And we say that the hollow organs gonna release bacterial material, septic material, and so it's gonna cause bacterial issue, infection, and can lead to septic issues, while the blood will cause shock and also it will irritate it. So that's what's gonna happen. So know which content is gonna be released by which organ and how it will affect the peritoneum. So the bottom line is whichever one is released can eventually cause peritonitis, which is inflammation of the peritoneum. And so they will start with mild pain at first, and as it gets worse, then more localized, and then we will see where it's gonna come into referred pain because of the same visceral and parietal peritoneum. They have nerves that's connected on these layers, and so it is the outside layer, which is the parietal. Yes.
Let me see about the page at the previous.
All right, quickly.
Good, sir.
All right. So you have nerves that are connected to the peritoneum, whether the visceral or the parietal. So the parietal one nerves are connected to the spinal cord, while the visceral nerves are supplied by the autonomic nervous system. So depends on which one is affected first, then you will have, if it's the visceral, the pain will be more dull pain, and as it gets worse, then you will progress, that will be affected into the parietal peritoneum, and so you'll get a more localized issue. Also, because of the layers that is there, you can have referred pain. So bear that in mind. A person will have local pain from appendix at the right lower quadrant, but also they can have referred pain that can go up to the shoulder. So that's because of the nerves, so bear that in mind. So when you assess a patient, you'll ask, are you feeling pain elsewhere? They will tell you, yes, that's the same thing, referred pain. Same thing with a person having a heart attack. They'll have the left chest pain, but they can also have left jaw pain or arm pain. So just understand that that's caused from the nerves that are connected. So acute abdomen refers to sudden onset of abdominal pain. So the word acute, always sudden. Chronic mean over time. So acute abdomen, they just develop this sudden chest abdominal pain and often associated with severe progressive problem. So the problem can be there and just cause a severe action, and so they will develop this pain. So you use your assessment and get your history. Did the pain occur suddenly or it develop over time? So your OPQRST question will lead you to what is going on and give an idea, because different organs will present different way, different issue. But again, we're not really diagnosing the underlying cause definitively, but it will guide us in our assessment and management of the patient. So we said that peritonitis is inflammation of the peritoneum, typically causes ileus. So what is ileus? Ileus is, we said that peristalsis is when the stuff is moving along into the alimentary canal. So the progression, the wave-like motion causes it to be moving. When you have ileus now is when there is some issue that causes paralysis of this movement. So this movement is not occurring as it should, or so there's an issue. So it causes distension of the intestinal tract and obstruction is there. So that is what you need to know, that ileus is paralysis of the muscular contractions, and you have retained gas and feces cause distension. Stomach empties by emesis or vomiting. So if there's a blockage and it's not moving in the direction to go towards the anus, then if it's become distended to the point that you have to get it out, then the person is gonna vomit and it's gonna come up via your mouth. We said that the alimentary canal start from your mouth to your anus. So if it cannot go one way, the body is gonna try to get it out the other way. So it's gonna come in emesis, and then you're gonna see the content of it, whether it is bright bloody or it's dark or the coffee brown. So you're gonna see if it's bright red, then you know so it's coming from the upper tract. If it's dark coffee brown, then you know so it's digestive stuff that is coming up in your emesis, and emesis is vomit. So some other problems that you can have is diverticulitis, and that's where you have the pockets and the form on the wall of the mainly the colon. So there's some weakening here on the colon, and when there's movement, there can cause that area to project out, and you have like a pouch forming. So diverticulitis is when you have fecal matter collecting in these pouches and inflammation occur. So the pouch, they refer to it as diverticulum or diverticula. So when they become inflamed, that's diverticulitis. Cholecystitis is, again, titis is there, so it's inflammation, but where it is the gallbladder. So cystitis is the urinary bladder, but cholecystitis is inflammation of the gallbladder. So know them different. And once the gallbladder is inflamed, then there's some obstruction and it can cause serious complications. So remember, the function of the gallbladder is to release the bile, and if the bile cannot be released, then you're gonna have problem with the emulsification of the fats. So you can have complications from it. So as we're looking at abdominal pain, and we said from beginning that a whole host of things can cause abdominal pain, and it's not for us to try and definitively diagnose what is causing it, but it's to get an idea and treat what we are presented with. So two types of nerves supply the peritoneum, and I mentioned them before. So for the parietal peritoneum, which is the one lining the abdominal cavity wall itself, then it's supplied by nerves from the spinal cord gonna be supplying that area. So supplied by same nerves that supply the skin of the abdomen. And so when there is pressure there, the person can perceive the pain, touch, pressure, heat, cold, just like regular nerve sensation. But the visceral peritoneum is supplied by the autonomic nervous system. So it's a deeper area. So the person will say they have a dull pain. They can relocalize it because it's not so perceptive, but they can have referred pain. So we said that it's gonna maybe come in contact with the next set of nerves from the parietal peritoneum, and if it's close, then you have the pain locally, but it can be referred to other areas. So bear that in mind when you're assessing your patient. So that's what we are talking about. The gallbladder is the problem. So the cholecystitis is there with the gallbladder inflamed, and because of the referred the nerves that are connected, it will cause the contact is close to the parietal nerves, and so you will have the person feeling pain up at their right shoulder. So bear that in mind. And the same thing with appendicitis. The pain is down at the lower quadrant, lower right quadrant. It can cause referred pain along the area there. So bear that in mind when you're assessing a patient. So you can use that to get information and better understand what's going on. Are you hearing me, class?
Yes, sir. Loud and clear.
Okay. All right. So another issue you can have is ulcers. So the protective layer of the mucus erodes. So your gastrointestinal tract with mucus. So it's especially in the stomach. So you have that layer there because of the acidic content. So the pyloric acid, which is in the stomach, will cause serious issue if the stomach was not lined with this mucus. But sometimes this mucus become eroded, and so the acid now eat into the organ, and that's where you have the ulcers developing. Sometimes it can eat into it, so you have the acidic content coming outside of the stomach itself and emptying into the peritoneum. So it may lead to gastric bleeding. Some heal without intervention. So it can heal itself, but sometimes it needs to be dealt with. Intervention have to be done to deal with it. Another complication you can have is gallstones. So we know that the gallbladder is there to produce bile, which is coming from the liver. When gallstone develop, these stuff becomes solidified, and it can obstruct the passage of the bile into the ducts and going into the small intestine to emulsify the fat. And so gallstone may form and block its outlet, causes pain and lead to cholecystitis. So the gallbladder become inflamed because of the blockage by the gallstone and cause the content to remain in the gallbladder instead of going out, and so it causes inflammation, and so they can have the serious pain, which is it can become referred because of the nerves that interconnect between layers. So pancreatitis is another condition that can develop, which is inflammation of the pancreas, and we say that the pancreas produces the pancreatic juice that helps with the breakdown of the protein. So it can cause obstruction of gallstone. So the problem affect the it can be obstructed by gallstone, and so it can cause from alcohol abuse or other diseases. So whatever the cause is the pancreas become inflamed, and so the person will have pain, and we see these include pain in the upper left and right quadrant. So know where it is located, and it can cause the pain to be referred also. But you will have, end result, the person will become nauseated, vomit, and abdominal distension. So bear that in mind. Sepsis or hemorrhage may occur. So you can have bleeding, or you can have contents release that can cause infection and lead to sepsis. So again, the primary thing the person will be complaining of is the pain. So that's what we're gonna get called serious abdominal pain, You come and you assess, you realize you're having the pain, then based on your knowledge of the anatomy, then you can think that maybe it could be related to pancreatitis. But again, we are not gonna diagnose and definitively know what is causing it. Just treat the patient accordingly. Still hearing me okay?
Yes, sir.
Okay, so appendicitis. So all of the itis we get in here now. So know the structures and know what is the problem, which one is having the problem based on the name. So it is inflammation or infection in the appendix. So the appendix is right at the junction of the beginning of the large intestine. So right where you have the cecum, that's where you're gonna have the appendix. Is just an area that is not outpoaching of the colon. So they say it have no useful purpose, but it is there. So fecal matter moving in the large intestine will become compacted in that area, and it can cause it to become inflamed. And they have 3 stages, they say, to that. It can be inflamed, or it can become ripened, that ready to burst, or it can actually burst or rupture. So that's what will happen. So varying degree of things can happen with the appendix. Most of the time, look, just having the pain, and so they can suspect based on the area that is having the pain. So once a person is having right lower quadrant pain, suspect appendicitis. So they will have nausea, vomiting, anorexia, and anorexia is lack of appetite. So they will eventually go up to fever, chills, rebound tenderness. Most of the time they said that these persons might not have a high fever. So don't look for the fever necessary to say that it's appendicitis. You can have gastrointestinal hemorrhage. So the tract can rupture, contents can leak out into the peritoneum. Maybe acute or chronic. So acute meaning it can happen suddenly, or it can happen built up over time. Problem is here, and eventually you can have contents leaking out of it. Still hearing me, class?
I hear you, sir. I hear you. I hear you.
Okay. All right. So esophagitis, inflammation of the esophagus, and we see that the esophagus comes from the connection to the stomach. So that's that tubular section that comes down, and it can also become inflamed. So acid from the stomach, we say there is a valve there that will prevent the regurgitation of substance. But sometimes if there's a blockage further down, then the stuff will build up and it can overcome that valve, and so substance can come from the stomach, and we say that the pyloric acid is there and it can comes back up into the esophagus. The esophagus is not lined as well as the stomach with that mucus, and so it can cause serious problem when stomach acid goes back up into the esophagus. So they will have pain in swallowing, heartburn, nausea, vomiting, sores in the mouth. So that's a serious issue, but not as serious as esophageal varices. So with esophageal varices, the liver has what we call hepatic portal vein. So the whole intestinal tract is lined with blood vessels that are gonna take the nutrient back in the blood, goes to the liver where it is detoxified, and then back to the general circulation system and back to your heart. So the hepatic portal vein comes from the tract, and if there is a pressure buildup where there's a blockage in the liver, then the blood cannot flow properly, and so it's gonna back up into your esophagus. It's gonna overwhelm the membrane, just like how you have edema, pulmonary edema, the 2 walls there, and the blood move from the capillary into the alveoli sac. So the same thing happening here. Once the pressure build up from the blockage, then it's gonna overwhelm that membrane barrier and it's gonna leak back into the esophagus, and so it can cause serious issue where you have leakage, or it can cause serious problems. So capillary network in the esophagus leaks, and so you can have fatigue, weight loss, jaundice, anorexia, edema, abdominal pain. So bear that in mind. So this can be a serious complication more than the esophagitis. So all of these are complications that we can have and give rise to gastrointestinal emergencies, and most of them will be what we will find abdominal pain will be the main symptom. Now another thing that can happen is Malware Wheeze syndrome. So the junction between the esophagus and the stomach tears, and we say that's almost where you're looking at the valve there. So principal symptom is vomiting. So just make sure you know these terms and have an idea of what is going on. Again, we say it's not for us to diagnose them, but to have an idea of what can be happening. Gastrointestinal enteritis is another big one that we all know about, and this is where your bacterial infection, viral infection comes in via, most of the time, by what you eat or drink, and so it causes infection developing in the intestinal tract, and most of the time the person gonna end up having diarrhea. And this can last for a few days, it can last for weeks. So bear that in mind, that once a person, you get a call somebody having diarrhea and going non-stop diarrhea, then you should be thinking of gastroenteritis. Okay, so we talk about diverticulitis is fecal matter becomes caught in the colon wall, causing inflammation and infection, and the person gonna have fever, malaise, and body aches and chills. So again, have an idea what could be happening. Hemorrhoids, where you have these blood vessels that supplies the anal area, so they can become swollen and inflamed, and this is what we will call hemorrhoids. So a person who is straining to pass their stool can cause these blood vessels to become inflamed and swollen, and also in pregnancy there is pressure applied to them also that can lead to it. So some of them will be inside the rectum, while some will protrude on the outside. So you will see them externally, or it might be inside, but most of the time the inside one will just produce bright red bleeding. So when you go and pass your stool, you will notice that you will observe bleeding. That's the likely cause of it. Sometimes you will actually see the pouch extending out. Depends on what's happening with it. So that's hemorrhoids. So all of these are conditions relating to gastrointestinal system problems. When it comes on to the urinary system, you are looking at cystitis. So we have cholecystitis, which is dealing with the gallbladder, and that's in the part of the digestive system. So that's part of the gastrointestinal system. But now we are looking at the urinary bladder, which is gonna be, once that is infected or inflamed, that's cystitis. So know these two terms differently. You will see it coming up in your exams. So it is common, and we say that female more prone because they have a shorter urethra. So also called urinary tract infection. So your term UTI, caused by a bacterial infection. So the infection will come via the vagina or from via the penis, and it's gonna enter that tract, the urethra, and it's gonna progress upwards to the urinary bladder. It can move from there in worst case scenario, and it can reach your kidneys, and so you can have problem with your kidney, a very serious problem. So go ahead.
Yes, is cystitis similar to ovarian cyst, or is that a different thing?
No, different thing.
Okay.
Different thing. Remember, we say it is the urinary bladder. It's cystitis. So ovarian cyst is dealing with the ovaries. So you will see more about that later on when we're doing gynecological emergencies. So caused by bacterial infection becomes serious if infection spread to kidneys. Reports of urinary urgency and frequency. So it's gonna affect their ability to pass the urine. And you will notice sometimes might have blood in the urine. So play a major role with dealing with the kidneys now. So the kidneys will say major role in maintaining homeostasis, help with maintaining the acid-base balance, blood pressure. So eliminate waste because it filters the waste from the blood. When the kidney fails, uremia results, and so that's where they having problem passing the urine. So waste product urea remains in the blood. Kidney stones can grow over time and cause blockage. So that can be one of the issues. So kidneys play a vital role, and once it become affected, we say if they cannot have a transplant, then they will have to end up with dialysis. So acute kidney failure means that it occurs suddenly, sudden decrease in kidney function. So once they are decreasing the kidney function to a certain level, then that's the beginning of kidney failure, and that's sudden or acute. Reversible with prompt diagnosis and treatment. So once you pick it up, it can be treated readily, but once it reaches the stage where it becomes chronic kidney failure, then the kidney has been damaged to a point where it's irreversible. So that's where they're gonna have to get a transplant, or eventual dialysis can keep them to a point until they get it, or they can manage their succumb. So progressive develop over months and years. Again, we say there are some risk factors that predispose a person to it. Same alcohol can predispose. Anything diabetes, we say that gonna cause the kidney to work too hard, can set them up for it. So female reproductive system and organs, you're gonna look at gynecological problems of a common cause of acute abdomen. So problem with the reproductive system can set the person up for the abdominal pain. So recognize that these structures are there in the retroperitoneal space, and they can show the same pain just like other structures are a part of the gastrointestinal system. So don't have a tunnel vision. Be open to the fact that it can either be coming from the gastrointestinal system, the urinary system, or the genital system. So do your assessment and look at your sign and symptom, be aware of what can be happening. But at the end of the day, you're gonna just stabilize life threats, package your patient appropriately, and transport. So lower quadrant pain may relate to the ovaries, fallopian tubes, or uterus, and we're gonna look more on that later when we do gynecological emergencies. So other organ systems that are there, the aorta lies immediately behind the peritoneum, and so weak ears can result in abdominal aortic aneurysm, AAA. So the aorta can rupture, it can dissect, and so you need to recognize that that's a possibility when a person having that pain there, and you will normally see it if it's ruptured. You'll have pulsation, and mass develops. So once a person, you're gonna assess the abdomen first before you touch it or palpate it. Look to see if you can see any obvious palpation, or not palpation, any pulsation, and that can indicate that there's a ruptured aorta, descending aorta has been ruptured. So within the abdomen, pneumonia can cause ileus and abdominal pain. So these are some conditions. So even respiratory issue can affect the abdomen, because we say the nerves that is there can refer it down to your abdomen. And also remember that the diaphragm is the line that separates the abdominal cavity from the chest cavity. So you can have problem there showing up in the abdomen from the respiratory system. Okay, other problem that can happen there is that you can have hernias can occur. So a weakening area of the abdominal wall can cause organs to protrude out, and so that can be an issue. So you can have protrusion of an organ or tissue through an opening into a body cavity where it does not belong. Can you hear me, class?
Yes, sir.
Okay. So may not always produce noticeable mass or lump, and also we can have what we call they can reduce by themselves. So the weakening area can be there, and it can be just going against that wall, but sometimes it's gonna protrude and cannot retract, and we call it can become strangulated because the wall that is coming out through can squeeze on that organ and cause circulation issues, and so it can be a serious emergency. So whatever organ is being protruded, you normally, just like an abdominal evisceration, you're gonna cover it with a moist sterile gauze and transport your patient appropriately. So serious hernia signs and symptoms are formerly reducible mass that is no longer reducible. So it used to be going in by itself, now it cannot, and it becomes strangulated and run the risk of losing circulation, and so you're gonna have pain developing, tenderness, and red and blue skin color discoloration. That's telling you that it is having circulation issues. So general patient assessment will be the same. We don't have to go too deep into this, but just be mindful that you're gonna follow your same patient assessment steps. Scene safety will always be a must. Make sure the scene is safe, and these patients might have contents, especially fecal matter might be there in the area. So make sure you have your PPE. If you need to have on your gown, your protective shoes. And another thing that can hit you is the stench of the fecal matter. So be mindful that they say once the scent is overpowering, just stay in the room for a little while, and your olfactory nerves will adjust to it, and after a while it won't be so overpowering. Mechanism of injury, you must assess for possibility of violence, because some abdominal issue can be related to trauma, assault. So be mindful of your safety at all times, and consider what is the MOI or NOI, and also possibility that the person can be having abdominal aortic issues. So characteristic odor or gastrointestinal bleeding. So check your MOI, NOI, determine the number of patients, make sure you protect yourself. You go to your primary assessment. If you have to call for assistance, you call for it. You do your primary assessment. ABCs as always. Abdominal pain may cause shallow, inadequate respiration. They are guarding the area to prevent the pain, and so they might be breathing shallow. So you might have to eventually breathe for them. So make sure you have adequate patent airway, ventilation is adequate, and also check for circulation. There could be sign of bleeding, so check for bleeding, check skin, check pulse, make your transport priority, do your rapid scan if you need to, and make your decision and prioritize the patient transport accordingly, and you follow up with your secondary assessment. History taking gonna be a big issue, so make sure you do your OPQRST, your sample history, and assess the patient accordingly. Present history of present illness, and past history will guide you. And again, when you're going to assess the abdomen, if you need to palpate, find out where the person is feeling the pain, and you're gonna go in a clockwise direction, starting from the quadrant away from the area of the pain, and come back to that pain quadrant last. If you start from the pain area first, then the person can guard it, and they naturally can try to guard it, and you will not get a true assessment. So normal abdomen is soft and not tender. Pain, tenderness, signs of acute abdomen. Expose and assess abdomen, palpate gently. So gently. And patient with these conditions, you're gonna transport them with less. You're gonna be concerned on their movement. So gently transport. Vital signs, you will always get the vital signs, and make sure you check their respiratory rate and pulse rate, which most of the time gonna be elevated. Reassessment, you're gonna do your reassessment just the same, and it's very key that you reassess these patients. Once it's a high priority, every 5 minutes, you must make sure you're doing your reassessment, and call in, notify the receiving facility, and inform them what is coming in. Patient with the abdominal issues will be more comfortable in a position where their knees are flexed, so it have less pressure on the abdomen. So as you look at the emergency care for each cases, you're gonna make sure that your ABCs are all right. Make sure that you need to ensure a patent airway, so you cannot treat causes of acute abdomen. So the patient need to go in for definitive care. So what we are doing is to provide comfort and lessen the effect of the shock if they are having signs of shock, and also low flow oxygen if indicated. If you need to go to high flow, then you go to high flow. So always titrate it based on the patient condition. After releasing the patient to hospital staff, clean the ambulance equipment and your hands. I guess remember we said that there can be fecal matter involved, so anything that is contaminated, make sure you decontaminate them and take it from there. So as we wrap up dialysis emergency, we say once there's a kidney failure, if it is irreversible, then they will have to do a transplant, and they will buy some time by getting dialysis. So there's two types of dialysis. There is the peritoneal dialysis, where they will insert a dialysis fluid in the abdomen and the peritoneum to do the same work that it will do when they take it out and put it in the machine. So they can hemodialyze, or you can insert the fluid in the peritoneum and try to get the blood treated and filtered. So you will have some cause that you go to, maybe which setting you're in, you might have persons have their home dialysis machine, and so you will have to relate to some of it in some cases, but just be mindful. Some services transport patient to and from dialysis center, but most of the time you get a call to a dialysis center for emergencies when they have some serious issue with the complications with the process, and the patient might be having some cardiac arrest or some issue that they need emergency care. So bear that in mind. So dialysis machine function much like the normal kidneys. Adverse effects of dialysis, they can become hypertensive, they can have cramping, and that's when the electrolyte imbalance, and they can have nausea, vomiting, hemorrhage from the access site, infection of the access site, and that's some of the cases where you'll be called to deal with them. So be mindful of that. So emergency care, as always, manage the ABCs, make sure you have patent airway, manage the breathing. If you need to ventilate for them, you ventilate, check their circulation, check for bleeding, control any bleeding, provide high flow oxygen if indicated. Sitting up is the best position because they can be having pulmonary edema. If they're in shock, then you'll keep them supine. Transport promptly. Safe, rapid transport. And we have come to the end of gastrointestinal and urologic emergencies. So if you have a quick question, you can ask it. Otherwise, we will break for lunch. Any quick question? Go ahead, Mr. Manning.
Yes, sir. It's a question I should have asked from the earlier break. Way back to the psychiatric emergencies, when you gave the acronym COSMAP. I didn't get the P. What the P stand for?
Perception. So remember, we said these persons are out of touch with reality. So when you're talking to them, you're gonna assess their perception, where they are down the line. They're going to tell you that they might be seeing all sort of things. So that's what they're gonna look at to assess their mental status. All right.
Okay, sir.
Any other question? All right. So yes, go ahead, Miss Wellington.
Sir, for most of the information, sir, that are here, like the pancreatitis and so forth, most of them carry the same signs and symptoms, right?
Yes, most of them.
Most of the
it's inflammation. Yes, once it's an inflammation, you know that you're gonna have possible fever, you're gonna have abdominal pain, because wherever this organ is, that area gonna have pain eventually, And the big thing is gonna be nausea and vomiting. So they're gonna all have similar things, but some of them will be unique to where they are. So the position is gonna be a key thing that tell you which one your thing is the issue. Remember, anatomy and physiology. The anatomy gonna tell you which quadrant the structure is at. So if the person is having pain, we say at right lower quadrant, then you know that the appendix is there. The cecum is there. The ascending colon start from there. So you give you an idea of what can be the issue. So you can have an idea by just the position, but most of them will have similar signs and symptoms. You're correct.
Okay, sir. Thank you. The other part of the question I was going to ask that you answer.
Okay. All right. Any other question? Okay. With that, we break for lunch. 5 past 1. 6 past 1. Okay.